Okay, good evening, the people in back home, and good evening, my dear sisters from Precious Blood, and everyone else who's able to join us. And if you're joining us from the Authentic Dialogue page, Karibu Sana. Today, our talk is on cancer awareness, and our presenter is Dr. Helena Musau, who's a consultant oncologist at Kenyatta University. Karibu, Helena.
Asante sana. Thank you very much for inviting me to speak to you this evening. So I hope we'll be able to share together, and I'm open for questions at the end, or if you feel like you want to communicate through the chat box, you can also do that. So it'll be a brief talk. I think I want us to talk a little bit more or have a little bit more of a chat towards the end. So you'll bear with me. I will try not to rush through it. If I speak too fast, just let me know as well. So that's the outline of what I'll talk about today. But just to let you know, what are the statistics of cancer in Kenya? These are the latest statistics that we have there from the International Association of Research in Cancer. And it just gets data from different countries in the world. And for Kenya, primarily gets data from the Nairobi Cancer Registry, which looks at cancer in Nairobi and its environs, and also from the Eldoret Cancer Registry, which is in the western part of Kenya. So the commonest cancer that we saw as of 2020 was breast cancer, followed by cervical cancer. These are primarily female cancers, and what we know about them is that they are cancers that we can screen for. Then we have prostate cancer, esophageal cancer, colorectal cancer, and then other cancers contribute to another half of the cancer burden in the country. The early symptoms in cancers, I don't know, I feel like I've jumped. So early symptoms of common cancers in Kenya, I think I'll come back to that after I talk about what is cancer. So cancer is a disease in which the body cells tend to grow uncontrollably. The normal check mechanisms for those cells is lost and they start growing uncontrollably. But what makes it dangerous is that these cells can spread to other parts of the body and form problems in those parts of the body where they spread to. Actually, we have two types. When we talk about cancer, many people will say, use other synonyms like a mass or a growth or a tumor. And when we talk about tumors, then we have to differentiate. There are two different types. They're the cancerous tumors, the ones that we've talked about, but there are also other tumors that we see, and those are benign tumors. And with benign tumors, they don't spread. So the characteristics of a malignant tumor is what we call a cancerous tumor. It spreads into or invades nearby tissues. It can travel to other parts of the bodies now to form other new tumors that can cause disruption in those different parts of the bodies. And many cancers form solid tumors, but we also have blood cancers such as leukemias, multiple myeloma that might not form solid tumors, but would present different problems in terms of the metabolism and even different things that we would see based on the cell types of the different blood cancers. Then the benign cancers, as I've said, those are not cancerous. They may be tissue masses that would grow, but they do not spread into or invade any of the nearby tissues. And then usually when we talk about how cancer will develop from one stage to another, what we tend to see is that a cancer, when it starts to grow, it grows locally where it is, or it has things that can happen to the cells that would make it start to become, so the precancerous stage or dysplasia or carcinoma in situ, sorry, I'm using medical terms, that's a stage when we don't have cancer, but the cells have the potential to become cancerous and don't look normal. They don't look like the normal cells. However, if they will become cancerous or not is always up to debate. There are some precancerous conditions that we know will definitely develop into cancers. There are others that we are not very sure of how they will behave. But once we have a cancer that has a potential to spread, what we find is that it tends to just grow locally where it is. And in that stage, we say it's a localized cancer. We have locally advanced cancer, where you have the cancer still within the organ where it started. It may have spread to some nodes or not, but mostly it's just a little bit bigger than the localized one. And then there's the late locally advanced cancer, where you find that it's not just where it started, but is probably involving regional lymph nodes, which is the first station of how cancer spread, and then we have got cancer that has spread to other distant sites of the body, and that's what we call metastatic cancer, or the cancer has metastasized. So when we talk about localized cancer, early locally advanced, late locally advanced, metastatic cancer, then that's when you hear people talking about stages. So your precancerous stage, when the cells are just looking abnormal, that would be like your stage 0. Your localized disease would be stage 1. Your early locally advanced would be stage 2. Your late locally advanced would be stage 3. And your metastatic disease would be stage 4. Now, with patients who have got precancerous lesions, we can be able to manage that. And in instances where we can be able to treat so that it doesn't develop into cancer, for those that we know are gonna likely develop into cancer. An example would be like cervical cancer for ladies. There are tests that we do. Nowadays there's a HPV testing that we do. There's the visual inspection that we're able to do. And there's also the pap smear that we're able to do. And all of those would be to help us identify if the chances of getting cancer. So with the HPV testing, we do know that the HPV, which is the human papilloma virus, is a virus that has got different strains, more than 100 strains, but there are certain strains of the virus that would predispose one or give one a higher chance of developing cancer. So it causes changes in the cervical cancer cells. With the pap smear, we're able to see the cells of the cervix itself and be able to assess whether they are normal or abnormal. And with the visual inspection, we are actually able to see the cervix, and by painting it with certain chemicals, we're able to tell whether they have abnormal patches or not, and we can target those for biopsy. Now, when we have a localized cancer and locally advanced and even late locally advanced, we can still give these patients treatment with a potential to cure them. And with metastatic cancer, more often than not, these are not patients that we shall be curing, but this scenario is slowly changing with new drugs that are available in the market. We're able to give them treatments nowadays that even if we're not able to cure them 100%, we're able to manage the disease more like we manage, diabetes or even hypertension. You're just on medication for a prolonged period of time, but the disease is under control. In certain circumstances, some of these drugs are so effective that we're actually able to get cures with the treatment. So it's not known why one person will develop cancer versus another person. And I always use the example of a couple that I saw, and the husband was a very, very heavy smoker, person who smoked like 2.5 packs a day. And in their 70s, the wife is the one who got cancer, whilst the husband didn't. And she actually got lung cancer. We do know that secondary smoke inhalation could be a predisposing factor, but why is it that she was not the one who was primarily smoking and, she got the cancer? So it's not clear. There are probably certain things about our genetics that we need to look into to figure out why it is that one person develops cancer, even when they are exposed to various risk factors, whilst another one will not. So risk factors, they attribute, it's any attribute characteristic of exposure that would increase the likelihood of developing cancer. So whilst we might not know what causes cancer, we do know that there are certain things that would increase the likelihood of getting cancer. Sadly, the older you are, the higher your risk of developing cancer. They usually say cancer is a disease of the elderly, and most of the people that we do see with cancer are 60 years and above. However, we must note that cancer can be diagnosed at any age. We do have children that have cancer. We do have neonates and infants that have cancer. And so it is not a disease that is, a prerogative of the elderly, but more often than not, when you look at different malignancies, you'll find that they occur in the older age group. We tend to see cancer a lot younger nowadays, and we need to look as to why that is. Is it our diet? Is it the soils? Is it exposure from the environmental factors? But what we do know is we're seeing cancer a lot younger than we used to in the past. Then some cancers are more common in men, such as colon cancer, stomach cancer. Others are only there in women, such as, ovarian cancer, cervical cancer. Breast cancer is more common in women than in men, and prostate cancer will only be found in men. Then in terms of race, cancers have been noted to be some cancers have been noted to be more common in Black population, or the African population, or the African American population, and are also noted to be a little bit more aggressive in this race. So you'll find that prostate cancer, it occurs much earlier in Africans than it does in, say, the Asian population, the Caucasian population. Breast cancer, lung cancer, breast cancer not so much, but we do see a lot more aggressive breast cancer in the African population. Lung cancer, colon cancer, rectum cancer, the same. So it will surprise you to note that only about 5 to 10% of all cancers actually have got a genetic predisposition. Majority of the cancers that we see do not have a genetic predisposition. It is what we'd say bahati mbaya, something that has just happened that we cannot explain why it has happened. However, for those patients that we do find that they have a genetic predisposition, then we need to be able to offer them genetic counseling, where the family can consider the risks and the benefits of having the testing, and if they're able to be tested, to be able to make decisions that could reduce their risk of getting cancers. We have to also know that there are limitations in genetic testing. Just because you test for a gene does not mean that you will get that particular cancer, and it also does not mean that you're not susceptible to other types of malignancies as well. Tobacco use. I think this substance, nicotine, has been one of the substances that has been known to cause cancer, and not just one cancer, a myriad of cancers. And it's not just smoking of tobacco, even chewing tobacco, sniffing tobacco. And it's the biggest preventable risk factor that we can find. And that's why there's a lot of efforts, even from the WHO, on smoking cessation and tobacco prevention. You don't see the adverts we saw when we were growing up of Embassy Kings, Smooth All the Way, and or Rosta, or people smoking in public. Thankfully, in Kenya, you can't smoke in public, but in other countries, that law is not yet been enforced. So it's been implicated not just in malignancy, in cancers, but it's also a risk factor for cardiovascular diseases as well. Then alcohol, your tipple can make you be at a higher risk of getting a cancer. The risk factor for many cancers with heavy alcohol use would be mostly cancers in the GIT. The mouth, the esophagus, the stomach, the liver, the intestines as well, but also cancers in the airway, so the throat and the voice box. And we do know that for people who are very heavy drinkers, they also tend to be some of them tend to be smokers, so that's, like a double whammy, having two big risk factors that would be, put you at a greater risk of developing cancer. Having two risk factors that would put you at a greater risk of developing cancer. Then we have infectious agents that we talk about. So I'll talk about viruses. I talked about human papilloma virus, HPV virus, which is been known to cause quite a number of cancers. Actually, the commonest cancer that we have seen it causing has been cervical cancer, but it does cause cancers of the anus, the rectal region. It does cause cancers in the airway, so in the throat as well. We've seen cancers caused by human papilloma virus. Then there's the hepatitis B and C viruses, and these have been known to cause liver cancer. And then there's HIV. Whilst HIV does not predispose you to getting certain cancers, it has been linked to have a higher predisposition to getting cervical cancer, a specific type of a brain cancer, which is called a primary CNS lymphoma, and a special type of skin cancer, which is called Kaposi sarcoma. So we do see different cancers from different types of viruses. There are others that I've not talked about. These are the 3 or 4 most common cancers that we see that is linked with viruses that we see that is linked with the development of cancer. Then our diet, we can never emphasize on, a wholesome, healthy, balanced diet. They say health is wealth, and it starts on the plate. So a diet lacking in fruits and vegetables, particularly those that are packed with antioxidants, would be something that we need to look into because it could predispose you to getting cancers. Diets that are rich in processed foods, meat, particularly red meat and high sugar content, would also predisposing you to getting cancer. When we talk about meats, there's some research that has been done also on meat that is charred. So barbecue meats that are quite charred, that are just, they have a lot of tar in them, that would also cause you to getting cancer. And the WHO labeled processed meats, bacons and sausages as cancer causing, or having chemicals in them that would cause cancer. And then together with diet, we have to look at exercise or the lack of it. And so a sedentary lifestyle would contribute to that. And then obesity, which again would be contributed to by diet. Other things that we see causing cancer would be ultraviolet radiation from the sun. That has predisposition to causing skin cancers. The risk is especially worse in people who are born with skin defects and also albinos. Even in us Black people, we need to be able to protect ourselves from ultraviolet radiation. And then aflatoxins, we eat a lot of cereals in Kenya. We need to know how our cereals are stored. And we also need to know the levels of aflatoxin because it has been known to cause cancers such as liver cancer. Asbestos, roofs a long time ago used to be made with asbestos, and that was linked with a particular cancer in the lining of the lung called mesothelioma. Luckily, that is not the case anymore. But very old houses, especially like those old Kanjo houses, we need to check if the roofs are actually changed at some point. Otherwise, the residents living there could be getting exposure to asbestos. And then hormones, where we are slowly getting to the point of menopause and dealing with the symptoms of menopause. Sometimes people get hormone replacement therapy, but it could also put you at the risk of getting a cancer, particularly breast cancer. So we need to be aware of what hormone replacement therapy we are getting. I usually put this just for effect, but just to show you or to demystify or debunk some of the myths that we have with getting cancer. So we know that ionizing radiation, which is to the right of the screen, ionizing radiation can cause changes in the cells. And when we're talking about the sun, it kind of sits in the middle of between ionizing and non-ionizing. But when we're talking about ultraviolet radiation or the UV rays, UVA, UVB, then we are getting towards ionizing radiation. And that's why it's important to protect ourselves from the ultraviolet light. When we go towards X-rays, they don't have that much ionizing radiation, but we always say with medical imaging, we need to limit the use and only use it when it's appropriate. So it's not that everybody should be sent for scans every, willy-nilly, but we need to have judicious use of these equipment so that we can be able to limit the exposure at the end of the day. So people like children who are sick, because we usually get patients who will have different types of conditions. There are even protocols that we use so that the exposure to the children is less than when we are imaging an adult. Now, the things that I tend to be asked about quite a bit, the AC power lines, the mobile phone, the old radios, the TV, the microwave. The radiation is non-ionizing, and it has not been shown to cause any changes in the cells through various forms of research that has been done. So as of yet, it still remains safe to use and has not shown, but we can discuss that in a little while. Some of the warning signs of cancer would be a change in bowel or bladder habits. So you know your body best at the end of the day. Even when you present yourself to the doctor, we have to listen to you because you're the one who's able to tell us whether something is normal or abnormal. So you know how often you go, you know how regular you are. So if you start noticing you're less regular than you used to be, or the caliber of your stools is different from what it normally is, meaning that maybe you had thick stools, now you're having little thin pencil-like stools. Those should be things to worry about. If you're suddenly seeing blood in your stool, blood in your urine, actually, like, blood in your urine should not be something that you sit back and say, let me observe. So you should always be able to present to a physician. You'd rather be told there's nothing wrong than to imagine that you're fine and it's probably some food that you ate. Then a sore or a wound that does not heal, despite being given treatment and despite being managed, it just keeps persisting. That should be something that should be looked at. Unusual bleeding or discharge from anywhere in the body, we should be able to monitor that. We find patients coming in with cervical cancer and you ask them, did you have any, bleed, they come in bleeding, but then when you take a history and you ask them, did you have any bleeding after sexual intercourse, they say, I'd spot once or twice, but I just thought Mzee was being very, aggressive, or we were really into it. But that should not be normal, because you probably never used to bleed before, or you're having a discharge, maybe, from your nose, that is not normal and it's persistent, maybe just one nostril, and it might be bleeding as well. You need to have that looked at. Thickening or a lump in the breast or elsewhere in the body, those are things that we don't ignore. We need to have them investigated. Indigestion or difficulty in swallowing. And many of our patients that come with problems in the GIT system, it usually starts off quite innocuous and it's not anything that anyone would be able to pick up very early, but you need to be aware of, your normal, eating habits and how you tolerate foods. So if you suddenly find that any food you eat, you're getting a lot of acidity, have it checked out. It could just be an ulcer, but could be something else that is starting to brew. Any difficulty in swallowing, you used to eat, your food without having to swallow water in between, and suddenly you can't complete a meal without having a glass of water there next to you. That is something that you should worry about. An obvious change in a wart or a mole, we call them beauty spots sometimes, particularly in the African population, if they're on the soles of your feet. Always have it looked at by the dermatologist with a dermatoscope so that they can tell you whether it's a normal wart or mole or if it's something else. And then a nagging cough or hoarseness of voice that is not responding to treatment, that is not going away, or coughing up blood. Those are things that we need to be able to look at. But all is not lost. There's a lot that we can do. The thing is, if you do not have cancer, if you do not have any what we call non-communicable diseases, we need to get on the bandwagon to getting healthy, and so that we can enjoy our best lives as we're getting into them, our retirement years. Should be able to avoid tobacco and tobacco smoke, secondary smoke inhalation. You don't have to be the one primarily smoking it, but if you're around people who are smoking, you also need to be aware that you're also inhaling that tobacco. Limit alcohol consumption. The cardiologist will always tell you a glass of red wine is safe to have. We're not saying that you do not drink, but you need to limit your alcohol consumption and try to avoid spirits as much as possible, and also be aware that the limits that we have as women are very different from the limits that men have in terms of the alcohol. Then protect your skin from the sun, particularly the sun that is between midday to 2 p.m. When the sun is overhead, that's when the UV rays are quite high. And you can protect yourself with things like sunscreen. You can protect yourself with protective gear, like hats, sweaters, scarves, or long sleeved shirts, just to limit your exposure to the sun. Eat a healthy and a balanced diet. I don't think I can overemphasize this. We always say dawa ni chakula ya kwanza. And eating right makes you feel better. Eating right can reverse a lot of the things that you can see going wrong with your body. Control your weight, get into a weight that's healthy. I always say this one and then I smile to myself because I need to get also to take some of these points to, and use them on me. Eating right, controlling weight, exercising daily. I don't know how many of us are fully immunized and immunized against things like HPV, we probably missed that bandwagon, but hepatitis B, something that we were not immunized with as children. And then screening. If I could see maybe after this, a show of hands, how many of us have had our screening done this year, had a wellness check done, where you get your bloods tested, check your cholesterol, check your predisposition to getting diabetes, have your weight checked, have your breasts checked, have your mammogram done, have your pap smears done or your HPV tests done. If you have a risk of colon cancer or rectal cancer or stomach cancer, have any scopes done. I don't think we are very good at presenting to ourselves for screening tests. We usually go to a hospital or to a health facility when we have something wrong with our body, but we need to get into the habit of doing screening. I always tell people, give yourself a birthday present. If it's your birthday, then make sure, as much as you're planning a nice big celebration, make sure that you go and get something for yourself where you can get tested. And that's for you at the end of the day. So when they do screening, they're able to catch a cancer or a pre-malignant lesion or the precancerous lesions at a very early stage before the symptoms appear. And it's always best to catch something wrong at its early stage because we can be able to treat it or cure it. And usually when you go for a screening visit or a wellness check, they do a proper history and a physical exam. They do some tests, they may do some imaging. And if required, you may also be asked to do some genetic tests. They speak to you as they do these tests just to make sure that these tests are right for you, for your history, and also the impact that it will have on you. Thank you.
Thank you, Helena. As we wait for questions from the attendees, just talk. What about all these CMOS, all these things people are drinking out here? Are they helping anyone, or it's just hype?
I haven't heard about CMOS in terms of cancer. What about CMOS for other things?
I think it's been tajwad everywhere. I think everyone, you just slap CMOS here and then you're good to go. So no.
And you CMOS is one of those things. I'm not very conversant with it. I know it has been beneficial for sexual health and function, for reducing inflammation. And you see, markers that reduce inflammation reduce your risk of getting cancer as well. So that could be where we're playing it. I think it's also very rich in vitamin C. And we know vitamin C is an antioxidant. So I'd play with it on that way, but I'd need to do more research to be able to speak more on CMOS.
Okay. And could you just comment? I know we've lost a few individuals to cancer in PB, and we are just wondering, is it that there's more cancer, or we are diagnosing it better, or we are just more people?
I think it's a mix.
Okay.
I think we do have more cancer generally. They actually say by the year 2030, the burden of cancer will be more in sub-Saharan Africa than in the Western world. I think when we were growing up, cancer was not a disease or something that we ever thought about or even heard about. It was something that we read about from the Western world. Even the movies that we saw didn't even have a Black person in them. You know, there were all these white people, older, with a bucket spewing their guts out, their hair's fallen off. It was not something that we experienced as Black people, but we're seeing it a lot more. I think the incidence has definitely increased, but I also know that our capacity to be able to diagnose cancers has gone up. I would put it in internship many years ago, almost 20 years ago, when we were doing a ward round and we'd see a patient, it would be like, that one probably has cancer and they would always be in pain or screaming or have a very smelly wound. That one probably has cancer. Tell the family to come and take them home to go and die, and we'd move on. We'd actually never say, we need to do this test to figure out what cancer they have. As opposed to now, when we suspect that somebody might have a cancer, then we go further to figure out what cancer they have. We go further to figure out what stage is this cancer, and even further to see, are we able to manage this cancer? Or worst still, in worst case scenario, be able to offer palliative care or best supportive care to these people. So we do have an interplay where we have better diagnostics. So we have more pathologists in the country, we have better imaging in the country. We have access to more doctors that are able to have a higher index of suspicion and are able to diagnose cancers better. Then also the access to healthcare is there, unlike before, when a lot of the costs for healthcare were out of your pocket. So if you didn't do a Rarambe to figure out what was wrong with you, then you would never know what was wrong. So you'll always have people who will tell you, somebody and somebody dies, but if I think about it now, that must have been a cancer. So I think it's a play between the two. There's a lot more cancer generally, but we're also better at diagnosing cancer.
And do we have the capacity to manage cancer, or should we just head to India, as I always see people doing? Do we have the capacity?
We do.
Okay.
We actually have the capacity to manage these cancers. And we actually do give them standard of care, meaning that it's the care that you'd be able to receive even if you went to some of the best centers. And a lot of the times, this is also limited by your resource, the resources that you have. So if you have a lot of resources, you can receive top-notch treatment. If you have just your basic resource, which we are talking about, the National Hospital Insurance Fund, your NHIF, and you're able to access it for treatment, then you can get, by and large, your basic and even your second line treatments almost fully covered by the National Hospital Insurance Fund, which reduces your out-of-pocket costs. Now, should you get on a plane and jump to India? For some things, we do still send patients to India, but by and large, for the most common cancers, we're able to manage them at home quite effectively. I think we've had a history, and even if we're to pick on any of us, our history with cancer has not been a positive one, myself included. The history I have of cancer has not been positive, and that might be true or ring true for others. What you tend to find is that the people who get cured of cancer, and there are many at that, get back to the business of living. They don't sit down and shout about it. They don't have kamukunjis about it. We don't get to hear about it often because everyone forgets and, life moves on. But when we have somebody who's passed away, we remember that. It's quite an emotional time. And so we hang on to that. So I think we need to also start narrating a lot more positive cases of cancer, just to show that there is hope and that, treatment is available and it can assist and can cure.
Judith, I've seen you've unmuted yourself. Do you have a question? Okay. Mutindi.
Hi,
Mutindi,
how are you?
I'm fine. Oh, Mutindi, changia mada ku. Nice to see you.
Mimi sichangi, unajua mimi ni daktari ya kutoa watoto. Sasa oncology si yangu. Anyway, hi Dr. Musao. I think I communicated with you last year about a friend of mine whose mom was admitted at KU. Well, unfortunately, she passed away. Anyway, so now my mother had non-small cell lung cancer. That was, she passed away. Now, you remember Janet Weaver? I don't know which year you guys feel.
Yes, I remember Janet.
Yes. So Janet had non-small cell cancer. Her father had non-small cell cancer, and the sister is a pediatrician. And we're talking one day, and we asked ourselves, is this thing genetic? Because your dad had it, your sister had it. And we're like, is there a test for us to get screened? So the only thing I heard about was something like load, and I used to be a smoker in college, but that's many years ago. Anyway, so so we asked ourselves, is there genetic testing? But then again, even if it we can't know our lungs, So I understand there's something called, there was a particular I don't know if it's a sputum test or something I heard about, or a low dose CT scan screening for lung cancer. And the weird thing is, her brother has smoked. Her brother came to visit when we went to India, and he's been a smoker for many years. And when he came, I mean, thank God my mom was a medic, so we could actually joke around her diagnosis. So the brother says, "Hey, just if it's lungs, I thought this thing is for smokers. I mean, I've been smoking and you never even held a cigarette and you've got lung cancer. I might as well continue smoking. Thank God he quit. But of course we had to explain to him that if you got small cell, you probably share faster than her. So none of the chemo worked. And then the other hype about India, Posa, is you've still I don't know which patient you sent to India, but when people consult me and you tell me you have stage 4, really, I'll tell you, don't waste your money in India. We blew 3.8 million. And I just think, but it's because we couldn't convince my dad that we don't need to be here, because once we found it was stage 4 from PET scan, my mom being a nurse at Kenyatta knew we are done. But then we stayed. He said, I'm going to stay because of your dad. He thinks he has to do everything possible. They offered us cyber knife. I called Dr. Kenya in US. All of you know Priscilla Kenya. And Kenya said, Tindi, you guys just know, I'm not saying you don't treat your mom, but no, it's not going to work. Cyber knife works for earlier stage in cancer. Now, if you've got mets all over and your PET scan looks like a street in Dubai, it doesn't make sense. But we wouldn't convince my dad, and to him it was, I have to do everything I can to help my wife. So is there a screening for non-small cell cancer? There's something about some sputum test, and you can confirm that for me. Or is it there's something like a low dose CT something? Just confirm for me, please. And if you guys do it. Sorry, I talk a lot.
No, thank you. And
Some things don't
sorry
change.
about
No.
Okay, go
I'm
ahead,
sorry to hear.
Helena. Nimeona mkono
thank you.
yako, nitakuita. Helena, go ahead.
So thank you, and sorry to hear about your mom. But we do have screening guidelines that we follow for lung cancer. We don't do the sputum testing. It has not been shown to be beneficial as a screening tool, except for patients who present when they're symptomatic. So when they're symptomatic, then sometimes, and you're not able to do what we call a bronchoscopy, you're not able to have an instrument go down to the bronchus, which is the airway, to be able to visualize it, then we do tend to have, we can be able to, in those patients who are symptomatic, we can be able to do sputum for them. But generally, as a rule, to just do sputum tests to look for cancer, that would not be recommended. Then when we're talking about the low dose CTs, so low dose CTs can be used for screening, to screen for cancers, particularly lung cancer, and people who are at a high risk of developing lung cancer. Remember when I put up the picture for the electromagnetic spectrum, when we're using CT, we're using ionizing radiation. So we want to limit the exposure to that radiation. So with low dose CTs, because we know we're going to be doing them often, we don't do a proper CT, we do low dose. So we're just screening to see if there will be any nodules or any, what we call ground glass opacification, any areas that look a little bit abnormal. That we could be able to follow up. And this would be for people who have got maybe a family history of cancer, or people who are smokers, or people who have been, predisposed to smokers, where they have like secondhand smoke. For lung cancer as a genetic, sorry?
What would the schedule be like? Like for cervical cancer, breast cancer, we have a schedule. What would be the schedule be like?
I can chat here from the US side, because I hang out sometimes with pulmonary guys. So you have to have had a 20 pack year smoking, and you have to be between 50 and 80. Above 80, no one screens you, because if you die, you die. Yeah. I'm sorry to say that, but you have to have had a 20-year smoking history, and if you've quit smoking in the last 15 years. So not everyone gets the screening, and this is not for non-small cell cancer. It's the what is it called, the adenocarcinoma that's caused by smoking itself.
Yeah, it's non-small cell.
Yeah,
So for non-small,
and I think
so non-smokers you don't screen.
No, non-smokers, the insurance won't pay. And then non-smokers, we don't, because you see, unless they've had heavy secondhand smoking, we don't, no one screens them. Helena, is it the same? Okay, in Kenya, even getting a CT scan is I'm telling you, in a resource-rich nation no unscreens non-smokers?
In Kenya,
Well, for us here,
it
you
is,
can afford. Yeah.
yeah.
Oh, here
But
CT scan
it
is like a chest X-ray. You sneeze, someone does a CT scan. It's very annoying.
yeah. So
Mhm.
for us in Kenya, we don't have it in our national guidelines, but we do follow it. So we have some guidelines that are about to come out for TB and lung cancer, because we found a lot of our lung cancer patients are first misdiagnosed as having TB, and then eventually diagnosed with having cancer. So we are coming up with those guidelines, and in those guidelines, we are tending to follow more of the American model, where we take that history, but also in the setting of a communicable disease such as TB, also looking at it in terms of patients who are started on TB treatment and are not improving, then we'd be able to screen them with a CT scan, be able to check for lung cancer as well. But routinely, we have not been screening. The other thing to note is that in our population, as much as we say we have smokers, majority of the people don't smoke as much. The pack year histories that we see
It's the West.
would not be 20, 30, 40, as you'd see in the West, or even like say somewhere like South Africa. Our female smoking is really a very small percentage that we see. Majority of the people smoking would have pack year histories between 1 to about 10 on an average, and so would not be at a very high risk of developing lung cancer. That said, in terms of
Yeah,
a
because
genetic syndrome that causes
yeah.
lung cancer, I currently am not aware of any.
Thanks. I think that's what I need a clarity on that. And you're right, because my mom also was told she has TB. That's the first thing she was told. And then then she said, okay, she used to work in Sudan that time, and Sudan has a lot of TB, but she's vaccinated, she's never gotten it. So she decided, I'm taking my, she actually left the office at Kenyatta and went straight to get a CT scan. And that's when Dr. Wanga told her, Then she did a biopsy. But you're so right. She was told that she has diabetes. I think the other thing for me, I've learned with many patients, and I saw a girl who was 28 when we were in India, 28, and she'd been treated for epigastric pain. You've got ulcers. It's an intern in Nyeri who said, imewahi kuangaliwa, umeweka kitu wakaangalia, she had stomach CA. So I think even for me now, if someone tells me I have ulcers, I'm like, were they seen? And there's so much abuse of omeprazole. It's just too much. And I think the percentage of those who actually end up being diagnosed with CA stomach, like lung cancer, you're hardly gonna get it at an early stage. Yeah. Wow. Thanks
Yeah.
for that clarification. Thank you so much.
I have a story for lung cancer. Now that you shared yours, I might as well share mine, if you can indulge me. My
We
brother
got time.
passed away with stomach cancer, and he was diagnosed with ulcers for the longest time, just ulcers. And until it was my mother who actually noticed there was something wrong, because he'd come home, Sunday lunch, everybody, and he'd serve food, but he'd never finish his food. He'd take 3-4 spoons and be like, I'm full. And she told him, I've known you for a long time. That is not you. And these ulcers are not you either. Go get it checked out. And that's how he ended up being diagnosed with stomach cancer. Of course, also the whole India story that I also at some point fought. Cancer brings about a lot of panic when it's diagnosed. But I think the genesis is to say patients don't present late. They get lost in the health system, looking for somebody who will have that high index of suspicion and pick out that it was a cancer. You're lucky your mom was a nurse, so she was able to figure out, I need to do more. Somebody else would have said, it's okay, let me persist on this treatment of TB and and keep taking the TB treatment. Had my mother not told my brother, like, do not come back to this house until you tell me what is wrong with you, he probably would have just gone to the counter and bought more omeprazole, as he was used to doing. You'd self-diagnose, you were given this once, you go back, you'll get some relief, you'll keep at it. So this whole thing of also self-diagnosing, this whole thing of imagining that doctors are out to steal your money and you don't want to pay consultation and you'd rather just go to the pharmacy and pick medications. If you're having a recurrent problem, that's probably not going to be your best move. You need to probably, invest in proper investigations just to figure out what is going on before it's too late.
And for non-medics who might not know, trust your fourth, fifth, 10th instinct. Our friend, I'm not mentioning names because this has been live, who passed away, my very good friend who passed away in January, classmate, had palpated her lump on her breast when she was breastfeeding and went to the doctor here in the States. And the doctor was like, no. She was like, no. She insisted, and when they did the mammogram, it was positive for cancer. She underwent treatment, and that was in remission. But now the new tumor that she got, it's someone who insisted on checking her because she was having she just presented with diarrhea that wasn't ending. And when she went to the ER casualty in Kenya, the doctor was like, something is off, and then did the test, and that was the second tumor was the prognosis is usually very poor. But if you trust your 10th instinct, if something feels off, if your mother says you're looking off, trust your second, and just have the habit of having like a medic. I know it's on your side, like side bar Mutindi, side bar Helena. Me, I'm always willing to help you. Yeah, just talk to me on the side. I'll be like, do this and that, because people get screwed up. Even we make mistakes, but just trust your instincts. You always have to have a lawyer and a medic in your cap pocket. Where let's have a side chat. Just do it. Anne, ulikuwa na swali.
Maybe before Anne
thank you.
speaks, and maybe if I can just changia what Posa said, and also just to remind you, when we were talking about the symptoms, I said you're the custodian of your body. You know your body best. Even when you go to describe your symptoms to a doctor, you need to be sure that you explain yourself. But if you're not convinced, or if you're not satisfied with the review you've had, nobody stops you. You can have a second opinion, a third opinion, a fourth opinion. As long as you feel that something is wrong with you, seek attention for it.
Okay, Anne, go ahead.
Asante, lovely to see you all. And thank you, Dr. Musau. One of the things in my line of work, we tend to also maybe attribute a lot of the increasing cancers and some of the non-communicable diseases to the increased use of a lot of the toxic pesticides in agriculture. When we were growing up, or before that, there was not much resources or money to go and buy, even for example, on your cabro, to manage the cabro using Roundup or glyphosate and all that. And so I'm just wondering, do you think that's one of the things that's contributing? I remember glancing at a KEMRI report some years back where they were looking at the cancer belt in the central part of the country, going to Nairobi, places where there's a lot of horticulture, and a lot of intensive use of a lot of these highly hazardous pesticides, increased use of synthetic fertilizers. What would be your maybe comment, and have you done any studies or come across any studies that have gone to deeply look at areas where we are seeing increasing cases of cancer? I remember going to the field in a place in Meru, and that lady was telling me that in my village, we have so many cancer cases until KEMRI came, but they never really got the final maybe study that was done there, why the village, like every family was getting a family member or two being diagnosed with cancer. Thank you.
Yeah, so thank you for your question. It's actually one of the things that we emphasize when we're doing community talks in terms of pesticides. So the chemicals that we use, be they herbicides, insecticides, fungicides, those impregnating agents that they use, be able to understand that these are chemicals at the end of the day. And increased exposure to these chemicals, be it through the skin, be it through inhalation, be it through touching them, they can cause changes in the body if prolonged, if done for a prolonged period of time. Also consuming them, there are people who spray and the next minute they're harvesting. consumption of crop that has been, or produce that has been recently exposed to such chemicals can put one at risk as well. So they are on the high list of agents that would be called that would be causing cancers. I think there have been litigation against certain companies as well in terms of it causing cancers, different drugs like what you've mentioned, Roundup. We do advocate for use of protective gear when people are using pesticides. Unfortunately, if we are to achieve food security, we kind of have to have them. So it's a thing of what is the greater evil. So it's ensuring that we use some that are friendlier, some that are less hazardous, and always using protective gear. But definitely they can be risk factors that we see that could be affecting. It's funny that you mentioned Meru. I worked in Meru for like 2.5 years in the cancer clinic there. And it was one of the studies that we wanted to see. When Camry went there to do their study, they did it focused more on the Mira crop. Could it be the one that was causing the cancer, or exposure to it when it's being, what is it called, sprayed? Could it be the one that is causing the cancer? But they never came out with any positive association to show that it is what was linking to the cancer, whether the Mira or the pesticides. But that said, you see, with pesticides, people use different types of chemicals on their pests and on their animals. People's soil levels might have different amounts at the end of the day. So it would involve different sectors coming in to investigate, where you actually take soil samples, where you actually test crop randomly in a certain area, where you probably link that to the genetic makeup of or the genetic profile of that population, and be able to see if there's actually factors that you can be able to tell if that is what causes cancer. As of now, I don't think there's any such elaborate study that has been done in the country. There are small studies here and there, but I don't think anyone can tell you why a certain region would have particular cancers. In Bomet, they have a very high predisposition to esophageal cancer. This is a cancer that we tend to see in people in their 60s plus. They have cases as young as 15 years old sometimes with esophageal cancer. We don't know any genetic, test, genetic syndrome that causes cancer, esophageal cancer in families. But then you'll find families telling you that X had cancer, Y had cancer, Z had cancer, and they're all from the same family, such that now when they have a patient who comes in with an esophageal cancer, they tell the relatives, come for a free screening scope so that they can be able to assess the esophagus. So there are different pockets of different types of cancers in different areas in the country. Pesticides, herbicides, fungicides are known to be chemicals that have risk factors towards developing cancers, and we should be wary in how we use them. Always use protective gear. Always ensure you know where your produce is coming from. There's a lot of talk about organic foods, organic produce, even our livestock being organic or free range, and it's all to just ensure that we limit the amount of chemicals that we're getting exposed to at the end of the day.
And could you just touch on aflatoxin? I know that's because Kenya is one of the countries with a high aflatoxin content in their soils. So no matter what we do, we actually all consume grain that has aflatoxin. We just decided on a level that we can tolerate, and if it has any relation to the liver cancer. And just as a side note, in West Africa, hepatitis B is so prevalent that most of the cancers there from the liver, even the ones we see here in Minnesota, are from Hep B. They didn't, like us, they didn't vaccinate until 97, I think.
Yeah.
Aflatoxin, Helena, sorry.
So aflatoxins. So aflatoxins is a group of toxins that's produced by like fungi, and this fungi is found in certain crops or produce, particularly cereals. that we find. And the aflatoxin producing fungi, it usually can contaminate crops. So it can contaminate them at different stages, either at the point of storage, at the point of harvesting, or even in the field as they're growing. We do have high aflatoxin levels in our cereals in Kenya. I remember even a newspaper article one time saying that we are not safe. None of the, maize meal that we are eating has got good levels of aflatoxin. And that's it was not sure whether it was because of storage or whether it was contaminated at harvest or at the field. But the levels, basically when you consume high levels of aflatoxin, it goes to affect your liver and can predispose you to getting liver cirrhosis and thus getting liver cancer. So it's true that aflatoxins are dangerous, and there are things that we should be able to protect ourselves about by ensuring that the levels of foods that we have in terms of aflatoxins are checked, and we should be alerted to those levels. Unfortunately, we are only alerted when they're too high. And the other thing is to be able to, if you grow your own crop, then be able to ensure that you store it appropriately.
Okay. What for me, I think the last question. I know we are emphasizing on what is it called, cervical cancer vaccine, and we're giving it to. I think the ministry is only giving it to girls under 9. I know that the West is actually increasing the age up to 46. So most of you, except my senior over here, she outed herself, are likely to are likely to get it. Are we giving it beyond? Are we giving it beyond the Mutindi? This is you. What's the age limit for HPV vaccine in Kenya? Here, Tunafi, a progressive gynae will give you until 46.
So the one the government is issuing, I think, and Dr. Musa can correct me, I think is only, I think, for 11, is it 10 to 12 years old only? The one the government was issuing, then COVID came, then it just stopped. The one I know, which you want to go, and I think Cervarix, it's up to 26. That's what I know. We don't have Gardasil. So Cervarix covers HPV 16 and 18. Gardasil covers 16, 18, and genital warts. Dr. Musa, you correct me. Now I'm specializing in obstetrics. I'm forgetting my gynae. So yeah, but the one the government issued, the age limit was primary school, but I think there was standard 5 and standard 6 specifically. Then for Cervarix, what I know was that the age limit was 26. But I remember when they just brought into the market around 2007, 2008, I was working in Martin, and when they brought the vaccines, we didn't even get HPV testing. We just went and got it, and they gave us, because it was really new. So I got vaccinated. I didn't get HPV testing. But the last time we had a webinar with them, which is many, many years ago, they said the age limit was 26. But I was asking, if somebody is HPV negative, why can't they get the vaccine? Dr. Musau can clarify that now.
If somebody is HPV negative.
Positive.
Yeah. Oh, okay.
Negative.
Right, so,
I'm wondering why they can't get the vaccine.
Negative or positive, Mutindi?
If somebody's HPV negative, you're negative for the high risk viruses that cause cervical cancer and genital warts. Why can't you get the vaccine? Because for Cervarix, the company says the limit is 26.
So you actually can, if you're HPV negative, you're encouraged to get the vaccine. They always say up to about the age of 40, 45. Aswani, you said 46. But I know in Kenya, we do have some certain guidelines who give it up to the age of 45. So if you come in, you're HPV negative, you will be advised to get the vaccination done.
How much is HPV testing at KU? Sorry.
We don't do it.
It's so expensive elsewhere. Anyway,
oh gosh,
I know
this is being recorded. So we are in the process of getting it. Yes, we're in the process of getting it, but I think it's just small challenges, procurement issues and things like that. But it should be there soon. But in Kiambu County, they have a very strong HPV program. I actually laud them for what they've been able to do for that population, and they've gotten a lot of cancers early. So HPV, as we've talked about, the human papilloma virus, it has over 100 strains, but there are certain strains that can cause cancer, certain strains that can cause genital warts. We have got different vaccines available to be able to treat it. I think one has got only strains 16 and 18, as you've talked about, Cervarix, and then Gardasil has got the 6 of them. So 16, 18, 11, 33. No, 16, 18, 33, 34, and there's one I think that even has more than that. And they are in Kenya, the vaccination program for girls, and it targeted mostly girls, was advised by the data that looked at the sexual debut of young girls. And they found that the sexual debut of young girls was around the age of 9 years old.
No.
Yes. So
Who's
whether
having
it would
sex with 9-year-olds?
whether it would be consensual or whether it would be
Oh,
predatory
yeah.
sex that is happening. Yeah. So they found that around 9 years old, many girls would have had a sexual encounter. And in some communities, they're even getting married that young. So as a result, that was the age that was chosen. So they were targeting, I think the initial pilot targeted 10, 11, 12 or 10 to 12-year-olds. But when they came to roll out the program, then they agreed that they would be doing the vaccination for 9-year-olds who would probably not have started their sexual debut or would be at risk, and we would know that they're HPV negative. So they rolled it out. Sadly, COVID came and spoiled the vaccination schedule because it was being piloted primarily for schools. So we would be able to catch these girls when they're going to school. But it's back on board. It's being done. The aim is to ensure that, we have a high percentage of 9-year-olds covered, about 96%, and that will reduce cervical cancer for that generation in years to come. The thing with HPV is that we all kind of have HPV or different strains of HPV through contact or the other, but not all strains of HPV are gonna cause cancer, and most of the HPV that we get, it's self-limiting, or the body is able to shed off those viruses. The girls in other countries are vaccinated up to about 15 years old or 12 years old, and the boys are vaccinated as well, not just girls. Even boys are vaccinated because they're the ones who are the carriers and spread the HPV around. But we are challenged because in Kenya, we are challenged because of the resources. We rely on donor funding to be able to vaccinate. And so looking at the population that would benefit the most and looking at the resources that we have, I think that's why the 9-year-olds were chosen. And so the vaccination program is still ongoing. Of course, there are a lot of myths and misconceptions regarding vaccination, especially after the advent of COVID. But we still do encourage people to go and encourage their daughters to get vaccinated. And anyone who's under the age of 45 who is HPV negative, we do encourage them as well to get vaccinated.
Sawa. What's your, as in, if anything, what's your take-home message for today? Like, if everyone forgets everything, for me, is first of all, do your pap smears, have your kids vaccinated. Both of my children, boy and girl, have HPV vaccine in them. They're the most of our vaccinated children on earth. That's what I say. But what's your take-home, Helena? Because we need to sleep. We need to eat or sleep, and here we need to eat. Luya, we need to eat.
So I'm seeing Mutindi saying cervical cancer is preventable, and I agree, cervical cancer is preventable. Early detection is key. First of all, you're the custodian of your own body. If you find that there's something wrong with you, seek attention and do not be dismissed. Continue to seek attention until somebody can tell you what is actually happening with your body. But the other thing is that cancer is curable. I think we all tend to have a lot of negative connotations with cancer. and I mean, it's not the best diagnosis to get, but I want to tell you that cancer is curable. Cancer is something that we can manage very well, but early detection is key. We need to catch it early. So take good care of yourself, ensure that you go in for your screening tests. If you need vaccinations, get them. And yes, let's be healthy and stay healthy together.
Haya, ninafunga kituo. Of course, I have to tell you what thank you for coming, by the way. Let me tell you the next ngojeni kwanza nijue vile kushare. The next presentation will be by our own Penina Njeri. Penina, I think she goes by Njenga now. Are you able to see my screen?
Yes.
Yeah.
Yeah, so it will be on finances. So
No.
that's, oh, you're not able to see my screen?
I can see it.
It's coming slowly.
I can see it.
Okay, huyo wa
I can see
slow
it.
ni internet yako sasa. Our next talk is gonna be on money markets, I think. Okay, maneno ya pesa. It's Penina who will present it. And that will be next week. If you want to do a presentation, because this is just pilot stage, we are just faking it as we make it. Munione kando. You can always get my number somehow. Mutindi sutu present endometriosis one of these days. I'll get your number from. Yes.
Okay.
I'll get your number from
All right.
Njoki.
Okay,
Helena.
yes.
Helena, thank you very much. And the rest of the team who made it, asante sana. And I will avail the recording to I think RISPA and our class, and somehow it will reach your class, Mutindi. Muendele kusambaza. Asanteni.
Thank you very much.
Yes, and very good discussion. Bye-bye.
Good night.
Good night, everyone.
Good night.
Good night.
Good night.
Good night.